There are several most important chapters. We are trying to accumulate all the idea from those chapters, and I have been following Dr. Pritesh Singh. That book is really nice, and all important points are focused over here. So I'm not going to do modification or anything, and I'm going to just focus via my camera, and I'm going to read them. So it will be easy for learners just by watching YouTube the idea. Okay, and they don't need to uh, look at the book all the time. So mainly this is made for my own use. I find myself more efficient in this way. So I'm doing this one for myself, but I'm pretty sure that those doctors who are in the same situation as me will get benefit from this. Okay, so we are going to focus on the contents and camera, and reading is done in audio. We can get benefit. Okay, so let's see. This is just a try. The first one is patients with the following criteria are referred to designate burn center. Partial thickness, burns more than 10% TBSA. Burns involving the face, hands, feet, genitalia, perineum, or major joints. Any full thickness burn. Electrical burns, including lightning injury. Chemical burns, inhalation injury, burns in patients with pre-existing medical disorders that could complicate management, prolong recovery, or affect outcome. Any patients with burns and concomitant trauma, fracture in which burn injury poses the greater immediate risk for morbidity and mortality. Burned children in hospitals without qualified personnel or equipment to care for children. Burns in patients who will require special social, emotional, and long-term rehabilitative intervention. Severe burn, vascular permeability and edema, immunosuppression, decreased renal blood flow, altered hemodynamics, hypermetabolism, increased gut mucosal permeability. Pathophysiology of burn. Radiant heat loss is increased from the burn wound secondary to increased blood flow and integumentary loss. Heat loss also occurs because of evaporation of water from the burn wounds. This leads to significant fluid loss also. Significant burns are associated with massive release of inflammatory mediators both in wound and in other tissues. These mediators produce vasoconstriction and vasodilation, increased capillary permeability and edema locally and in distant organs. Immune system, global depression in immune function, depressed cellular function in all parts of immune system, activate including Activity of neutrophils, macrophages, B and T lymphocytes. Metabolism, increased release of catabolic hormones like catecholamines, corticosteroids, and glucagon leads to hypermetabolic state. Stress ulcers, Kernig's ulcers, or burns are due to decrease in mucosal defense. Acid secretion is not increased. Zone of coagulation, zone of stasis, zone of hyperemia. Epidermis and dermis. Pathophysiology of burns, area of cutaneous injury. Zone of coagulation, necrotic area of burn where cells have been disrupted, tissue is irreversibly damaged at the time of injury. Zone of stasis, area immediately surrounding the necrotic zone, moderate degree of insult with decreased tissue perfusion, and depending on the wound environment can either survive or progress to coagulative necrosis. Associated with vascular damage and vessel leakage lies beyond the zone of stasis, characterized by vasodilation from inflammation surrounding the burn wound. Contains clearly viable tissue from which the healing process begins, generally not at risk for further necrosis. Burns death. First degree, second degree, third degree, and fourth degree. So, in first degree, epidermal burn involves only epidermis. Do not blister erythematous because of dermal vasodilation. Painful, heal without scarring in 5 to 10 days. Partial thickness burn involve epidermis and some part of dermis divided into superficial and deep second degree. Full thickness burn involves all layers of dermis characterized by hard leathery scar that is painless and black, white or cherry red. No capillary refilling or pinprick sensation. All dermal and epidermal components are lost. Heals only by wound contracture, require excision with skin grafting to heal. And fourth degree involve other organs beneath the skin, such as muscle, bone, and brain. Superficial second degree involve upper layer of dermis, papillary dermis, erythematous. Blisters are thin, bland to touch, painful, heals without scarring in 7 to 14 days. Deep second degree, also known as deep partial thickness burn. Injury extends to reticular layer of dermis, don't blanch. Mottled pink and white color of wound surface. Capillary refilling is absent to occur slowly. Pain is absent. Pinprick sensation is preserved. Heals in 3 to 9 weeks with scar formation. Epidermis, dermis, fat, muscles, first degree, second degree, third degree, and fourth degree. Sclerotomy. Circumferential full-thickness burns to the limbs require emergency surgery to avoid compartment syndrome. Increasing the whole length of full-thickness burns treats tunicae. Effects of this injury: levels of sclerotomy, upper limb, mid-axil, anterior to elbow, medially to avoid the ulnar nerve. Hand, midline in the digits. Lower limb, mid-axil, posterior to ankle, medially to avoid saphenous nerve. Chest, down the chest, lateral to navel, across the chest, below clavicle, across the chest, at the level of xiphisternum. Fever in burn patients. Many of the physiological criteria that has been claimed to reflect sepsis are non-infectious manifestation of post-injury hypermetabolism. Hypothermia, 39 degrees centigrade or greater, is occasionally a febrile response to infection, particularly in children, but episodic elevation in temperature are common in uninfected burn patients. The hypermetabolic phase, mediated by greatly increased level of catecholamines, prostaglandin, glucagon, and cortisol, occurs after the acute phase and also produces pathophysiological changes. Burn patients exhibit increased blood flow to organs and tissues and increased internal core temperature, hyperproteinemia, and edema formation. Care of burn patients: cool the burn wound. This provides analgesia and shows the delayed microvascular damage that can occur after burn injury. Cooling should occur for a minimum of 10 minutes and effective up to 1 hour after burn injury. It is a particularly important first step in partial thickness burns, especially scalds. In temperate climates, cooling should be at about 15 degrees centigrade and hypothermia must be avoided. Room temperature. Water can be poured on the wound within 15 minutes of injury to decrease the depth of wound, but any subsequent measures to cool the wound are avoided to prevent hypothermia. Iced water should never be used even on the smallest of burns. If ice and cold water is used on large burns, systemic hypothermia often follows, and the associated cutaneous vasoconstriction can extend the thermal damage. The entire constricting scar must be incised longitudinally to completely relieve the impediment to blood flow. Superficial partial thickness burn with blisters heals without residual scarring in 2 weeks, irrespective of the dressing. Treatment is non-surgical. The simplest method of treating superficial burn is by exposure. Burn site: percentage BSA. Determination of burn size estimates the extent of injury. Burn size is accessed by Wallace Rule of 9 by Alfred Russel Wallace. Wallace Rule of 9 in adults. Each upper extremity 9%, head and neck 9%, lower extremities 18%, anterior and posterior aspect of trunk 18%, perineum and genitalia 1%. Children have relatively larger proportion of body surface area in their head and neck, which is compensated for by smallest relatively smaller surface area in the lower extremities. In infants, head and neck 21%, each leg 13%. Barco formula is used to accurately determine burn size in children. For estimating a smaller burns area of open hand, including palm and extended fingers of the patient, is approximately 1% of TBSA. This method is helpful in evaluating splash burns and burns of the mixed distribution. Fluid resuscitation. Intravenous fluid resuscitation in children with burns more than 10% TBSA and adults with burn more than 15% TBSA. Regimen of fluid resuscitation follows the fluid loss, which is at its maximum in first 8 hours and slows such that 2 to 36 hours the patient can be maintained on his or her normal daily requirement. Fluid used in resuscitation. Ring lactate is most commonly used. Some centers use human albumin, FFP, or hypertonic saline. If oral resuscitation is to be commenced, it is important that water given is not salt-free. Hyponatremia and water intoxication can be fatal. In children, maintenance fluid must be given, usually dextrose saline. Simplest and most widely used formula, Parkland formula. Hypertonic saline has been effective in treating burn shock. It produces hyperosmolality and hypernatremia. This reduces shift of intracellular water to the extracellular space. Advantage includes less tissue edema and resultant decrease in sclerotomies and intubation. Proteins should be given after the first 12 hours of burn. The commonest colloid-based formula is Moyer and Barclay formula. Monitoring of resuscitation. The key to monitor is urine output. Urine output should be 0.1 to 1 ml per kg per hour, 30 to 60 ml per hour. Acid-base balance and hematocrit in cardiac dysfunction, transesophageal USG, and central line. Venous access for infusion in adults. Ideal sites are veins in hands, antecubital fossa, or neck. Saphenous vein cut down is useful in patients with difficulty access and is used in preparation to central venous cannulation. CBP line is used for CBP monitoring, helps in estimating fluid overload. Resuscitation formula.